Thank you. Good morning, everybody. As was mentioned by David, we're going to switch gears away from a behavioral economics intervention to thinking about the potential effects of a structural intervention. But I'll look to you as the panel and the audience to help me understand the potential economic implications of this work. I'd like to acknowledge my co-authors, both from Brown University and also the Center for Excellence in HIV/AIDS in Vancouver. I have no conflicts of interest to declare. Homelessness is a global public health problem. Upwards of 100 million people experience homelessness in essentially every country around the world each year. HIV prevalence is greatly elevated in these populations. A recent systematic review published in The Lancet found that HIV prevalence varied between 0.3 and upwards of 20% among homeless people. And crucially, homelessness is a barrier to effective HIV treatment. Cohort studies have consistently found that homelessness interferes with many points along the HIV care continuum. We've seen how homelessness reduces the likelihood of ART initiation among previously diagnosed people and interferes with patients' ability to adhere to that treatment. Studies from Vancouver and other settings have shown that homelessness lowers rates of viral suppression at the individual level, likely operating through poor adherence pathways. And even among persons who do experience viral suppression, homelessness is associated with an increased risk of viral rebound and ART discontinuation. Now, in contrast to what I would consider a fairly robust and unequivocal observational literature, trial results in this area are sparse and generally inconclusive. Two studies have been conducted in the United States. One was a randomized control trial in Chicago, this one, that randomized 100 HIV-infected homeless persons leaving a hospital to immediate housing and intensive case management or usual care. And the second was a much larger study in 3 sites in the U.S. that randomized 600 people who were unstably housed to immediate federal housing provision through the HOPWA program or usual care. The smaller study found that the housed treated group had an almost 2-fold increased prevalence of viral suppression at 12 months, and unfortunately the larger study's results were essentially null. So in the context of these disparate findings and strong observational literature showing that homelessness has an effect on viral suppression at the individual level, we sought to answer really a very simple question. We wanted to find out what would happen if we could eliminate homelessness among a population of HIV-infected people who use drugs. And we're focusing on this population because they tend to be at tremendously high risk of poor HIV treatment outcomes and homelessness in many settings. Now, to do so, we employed a population intervention marginal modeling approach. In this method, we use observational data to estimate a causal effect of an intervention in which we house all homeless individuals and try to estimate the population viral suppression prevalence in that counterfactual scenario. And I'll go into that method more in a moment. The data for this analysis came from the AIDS care cohort to evaluate exposure to survival services, or access. This is an ongoing, community-recruited, prospective cohort of HIV-infected people who use drugs here in Vancouver. Most of the recruitment occurs through snowball sampling and referral, primarily in the downtown East Side neighborhood, which is just several blocks from where we are now. Participants complete an interview-administered behavioral questionnaire which elicits information about housing status, sociodemographic characteristics, substance use, medical care, addiction treatment, among other domains. And we rely on a confidential linkage to a province-wide HIV/AIDS registry, which contains information regarding HIV clinical care. And in this case, we were interested in examining results from viral load tests during those clinical care encounters. And I want to highlight that this is a setting of universal, no-cost HIV/AIDS care, and so we're able to eliminate the potential confounding effects of financial barriers to HIV treatment on the relationship between housing and viral suppression. For this particular analysis, 708 participants were eligible and completed at least one study visit during our period of interest. Our primary exposure, again, was absolute homelessness. People who reported living on the street with no fixed address in the past 6 months during the first study visit during this period. The outcome was viral load collected during the first encounter during routine clinical care, which occurred an average of 23 days following that behavioral questionnaire. And we define viral suppression as less than 50 copies per mil. We included in our models, which I'll present in a moment, other known risk factors for viral suppression or homelessness among HIV-infected people who use drugs. So the statistical analysis I'm going to walk you through now, it's really a two-step procedure. The first is a standard regression type approach where we seek to identify the independent relationship between homelessness and viral suppression. We use modified Poisson regression, which is appropriate for dichotomous non-rare outcomes. In these models, we did not adjust for factors that could lie on the causal pathway between homelessness and viral suppression, and that included access to health care, adherence patterns, and so on. In the next procedure, we sought to obtain this population intervention effect, and I'm happy to explain this in more detail following the talk. In brief, the first step is that we predict the outcome for each person conditional on the observed covariates, and then average these probabilities across the entire population to obtain a viral suppression prevalence which was actually observed. And then we create an imputed data set which represents a counterfactual scenario where we're able to house everyone in the study population. We essentially set homelessness to 0 for all. And we reapply the effect estimates from the previous model to obtain a new population viral suppression prevalence if all persons had in fact been housed. And we use bootstrapping to calculate 95% confidence intervals for these estimates. So just to give you an idea of the sample characteristics, just over a third were virally suppressed during that subsequent clinical care encounter, and just under a third reported recent homelessness during the interview. The majority of our participants were middle-aged, male, and of Caucasian racial ethnic origin. The vast majority had a history of injection drug use. Very few reported formal part-time or full-time employment, and around 40% reported being on methadone in the past 6 months prior to that interview. So here now are the final results from the population intervention model. This first bar shows you the predicted population viral suppression prevalence given the observed data. And the model predicted a 38% viral suppression prevalence, which is what we in fact observed, which suggests the model has validity. In our counterfactual scenarios in which we house all participants, viral suppression increased to 43% in the final adjusted model, which represents a 15% increase in the entire population, which was statistically significant. The results were even more dramatic when we looked specifically at the persons who were homeless during that first interview. The model predicted a 22% viral suppression prevalence, which was indeed what we observed empirically, and dramatically an 80% relative increase in viral suppression had all of those individuals been housed. What these figures really show is that the relationship between homelessness and viral suppression did not appear to be confounded by all of our measured covariates. So what can we learn from this study and from prior literature? I think we see clearly that housing programs should be implemented as part of comprehensive HIV prevention and treatment efforts. And I highlight the fact that what we're modeling here is absolute homelessness. The referent value is any housing status besides living absolutely on the street. And so we have strong evidence for low threshold shelters and other housing-first housing models, in addition, of course, to more higher threshold comprehensive supporting housing services for HIV-infected people who use drugs. Now, I do highlight that additional cost-effectiveness studies are warranted. Previous studies conducted in the United States show that these kinds of housing interventions cost between $10,000 and $12,000 per client per year. but that they do tend to be cost effective if we can avert even one HIV infection per 60 to 70 persons housed in these kinds of low threshold programs. But I think this is an active area that requires further investigation. So I just wanted to highlight some strengths and limitations and then summarize. Even though we're using methods which attempt essentially to emulate a randomized trial, we nonetheless have unmeasured confounding, and that must be recognized. And housing status, again, here was self-reported and subject to possible misclassification. And finally, I wanted to highlight the generalizability of these study findings. And this is an important issue when applying these methods. The estimate is highly dependent on the prevalence of the exposure in the population. If this study is replicated in other settings with different homelessness prevalences, you very well see different results, and that's a function of the model. So I wanted to conclude by not mincing my words. Homeless housing is a human right and should be provided regardless of HIV or drug use status. But nonetheless, our findings do show that interventions to house homeless HIV-infected people who use drugs could have significant population-level impacts on viral suppression prevalence, and thus should be part of comprehensive HIV prevention and treatment strategies around the world. So with that, I thank you for your attention and the many investigators and our funders